Let's begin the search here. Diabetes mellitus, a far too common disease, with well-established links to disorders of the macrocirculation, arteriosclerosis and atherosclerosis in particular. Also well-established are the disease's links to effects on the microcirculation of the eye, kidney, skeletal muscle, skin, peripheral nerves, pancreas, and adipose tissue. Almost a complete inventory of the human anatomy. Perhaps more common is the individual with hypertension, who, for the moment at least, enjoys his high-risk lifestyle. In addition to the toll he places on his macrocirculation by being overweight, hypertensive, and a heavy smoker, he is placing his microcirculation in jeopardy as well. Atherosclerosis is a disease of the macrocirculation, but the accumulation of lipids narrowing damaged vessel walls may also reduce flow to the microcirculation, helping to foster additional disabilities. The aging patient may face all of the above risks and then some due to impairment of the macrocirculation. Undoubtedly, there is also impairment of the microcirculation, and the combined effects can be devastating. Here, then, is the apparent contradiction. Therapies aimed at improving the macrocirculatory deficiencies of such patients do not offer similar benefits to the microcirculation. Why should one part of the circulatory system respond independently of another? Let us see. It is not only pain at rest or cold extremities that we need be concerned about. There is a danger of leg ulcers with the risk of infection due to the poor healing that often accompanies microcirculatory damage. Intermittent claudication, pain on effort, and skin necrosis may occur. There is the very real danger of ischemic brain disease, the risk of impaired intellectual ability. And the diabetic in particular risks retinal microangiopathies, risking potential loss of sight. Ironically, it is entirely possible to have a situation in which patients receive perfectly sound medical care for macrocirculatory deficits while remaining at risk from microcirculatory impairment and its ravages, a risk that should and can be dealt with. If a deficiency in the blood and oxygen supply can cause pain in the calf muscle, improving microcirculatory flow should offer relief. In a multi-center, double-blind, placebo-controlled study involving 93 patients, all of whom suffered from obstructive arterial diseases and intermittent claudication, Loftil demonstrated just that and more. The clinical significance is impressive. Equally meaningful is the improvement in the patient's sense of well-being, the sense that he is not diminishing, but restoring himself. Pain at rest is a sign of a more advanced stage of microcirculatory disorder than is intermittent claudication alone. Pain, especially pain that is capricious or seemingly unprovoked, is particularly debilitating. Its absence contributes much to the enjoyment of life and the outlook of living. The outlook now for diabetics, for all who suffer microcirculatory impairment, is significantly enhanced by this unusual molecule, a molecule ideally matched to the system it serves. There is no doubt as to its existence. No question as to its contribution to the human body. But exploration into this vast, invisible organ continues, re-examining the known in search of the possibilities. After all, the microcirculation is the pathway to the life of every cell in the body. Who knows in what other ways we may help it to deliver a fuller, more productive life?